Welcome to Changemakers. This is a webinar series brought to you by the Alberta Health Services Primary Healthcare Integration Network. In today's session, we have representatives from 3 multi-sectoral teams who have been working together to reduce the impact of financial strain. We call it RIFS for short, and you'll probably hear that throughout the session. We are excited to debut their digital stories and learn how they are tackling financial strain together with our community's primary care networks, AHS, community partners, and members. They will highlight how those lessons strengthened home to hospital to home transitions. We hope that you might use these stories to spark further conversations with your teams around these complex issues impacting health. Before we jump into today's session, we want to acknowledge that we have participants joining from across the province and that all land in Alberta is Indigenous land. We recognize that our AHS work and the work of our partners takes place across the province on the territories of Treaty 6, 7, and 8, and the homeland of the Métis. This includes the traditional meeting place and home for many Indigenous people, including the Cree, Anishinaabe, Blackfoot, Stoney Nakoda, Dene, Inuit, as identified in Treaty 6 and Métis Region 4 territories. We also acknowledge the many Indigenous communities that have been forged in urban centers across Alberta. Please note this session is being recorded and will be made available on our external site for shared learning purposes. The AHS Primary Healthcare Integration Network position is not affiliated with biases or opinions that may be presented in the recording today. If you have any questions, please email us at PHC Integration Network, phc.integrationnetwork@hs.ca. Also, if you do not wish your name to be made public, you can also email us any questions that we can bring forward for you. So throughout the session, feel free to ask your questions. Our team will be monitoring the chat box. We'll do our best to answer the questions. We've got a large group of panelists who will be chatting with you and also responding to your questions during the Q&A period. If we don't get to all those questions, we'll circle back with you with an email after the session. Any tech issues, please message Paula. Her information is on the screen for you. I'm your host, Shauna McGann. I'm with the Primary Healthcare team, and my co-host today is Crystal Lacombe with Alberta Medical Association. Both of us leads with the various aspects of reducing impact on financial strain. We're going to start by setting the scene, and I'm pleased to invite Dr. Linda Slocum. She's a family physician and a senior medical director for Primary Healthcare and Primary Healthcare Integration Network. Thank you, Linda, for sharing why this work matters.
Thanks, Shauna. Thanks for the introduction. And this is great work that's been going on in the background between this, as you said, the 3 groups, the AHS Integration Network, the Primary Care Networks, and the AMA ACT team. So thanks everybody for all your hard work in this and getting this presentation and webinar together. And I've watched the videos. You're really going to enjoy them. So you'll be looking forward to that. So setting the scene, why this work matters. I only have 5 minutes. So bottom line is, in my view, it's the right thing to do. It's as simple as that. Why? So income is one of the most important factors that influences health. And if you look over to the graph there, you'll see 50% social determinants of health. In medical school, I can assure you, we're taught the bottom 50%. So your biology, your environment, your healthcare system, and we focused on that, and we focus on that still today. However, if you see the social determinants of health, 50% are actually going to make you sick that we didn't even learn in medical school, and we still maybe don't discuss as a healthcare system, including things like early childhood and development, disability, you'll see there. And so that's why this work is so important. We need to be looking at the whole person to truly influence their health. And that's a new concept, believe it or not, for a lot of us. Next slide, please. So this one just shows you that for Alberta, when we talk about income being very important to someone's health, what's happened during the pandemic. I mean, we all know people who have lost their jobs, and the unemployment rate has dramatically increased over the last 6 months. It's now up to 15.5% in Alberta, and the highest in the country, unfortunately, due to many factors, but the pandemic has not helped. Next slide, or yeah. So then the Center for Addictions and Mental Health is tracking this, is very concerned, and as you can see, 60% of Canadians are somewhat or very worried about their finances. And as you saw from Alberta statistics, that's a lot of folks. 15% are unemployed, and then a large percentage also are worried about income. And if we're truly trying to affect healthcare in this province, then that has to be part of our discussions. Next slide. So I've seen this slide before. If only it were true that this health ecosystem was all integrated and we were all working together from the medical home out to the health neighborhood, which includes your primary care networks, your community pharmacies, home care, all the way out to the community supports, schools, finances, all of that in a fully functioning primary care healthcare system. We would all be working together and integrated. And that's really what this is about. The RIFS project is looking at how to bring that integration together. One of the other initiatives that's going on is the Alberta's Home to Hospital to Home Transitions Guideline. Now, and the Primary Healthcare Integration Network was key in helping to develop this. It is the only provincial guideline like it in the country. So it's a huge step forward in sort of truly trying to make the patient's journey improved from beginning to end, from their medical home, if they have to go into acute care, and then from acute care back out to their medical home. CII-CPAR, which some people have heard about, will help this because it's helping to integrate the system. But the idea is that the income supports that we're looking at helping folks with will be part of this, is part of this transition guideline, and will be moved forward once we get the guideline implemented across the province. So in this guideline, you'll see 6 major components, and the big ones are confirmation of the primary care provider, admit notification, transition planning, referral and access to community supports, transition care plan, and the follow-up to primary care. They're all very important, but as we heard even last night at a separate webinar, was that transition care plan, the referral and access to community supports, and the follow-up to primary care are some of the key parts of this guideline that need to be integrated. And today we'll be looking mostly at the access to community supports and how to help patients, particularly ones who have income issues, and then that follow-up to primary care, how to make that really integrated into the system. So that's why you're at this presentation. That's why we're doing this work. It's a new way of looking at patient care in terms of the whole patient, and then it's a new way of looking at integrating our system provincially, which has to be for patients the whole way through any patient journey in our system. And we're really working hard to get there. And these 2 initiatives, the RIFS project and Home to Hospital to Home Transition Guideline, are going to help us get there faster. So thanks for joining today, and I hope you enjoyed the rest of the webinar.
Thank you, Dr. Slocum. Awesome. As you say, it's truly a collaborative effort, and I've been asked to give a little bit of a background on reducing the impact on financial strain. These multi-sectoral teams set out to tackle a complex challenge, and they deepened their understanding of what can be done together. The teams were made up of, as you highlighted, AHS, primary care networks, and community members and partners who used the Alberta Healthy Communities approach and human-centered design. So in a moment, you'll hear their inspiring journeys of how have they strengthened those connections? How did they start from a place of empathy? How did they start the conversations to identify and respond to financial concerns? And how are they building that capacity to respond collectively? The 3 primary care networks leveraged this tool as a starting place. It is the Alberta version of the College of Family Physicians of Canada clinical tool used to help primary care identify patients who suffer with health issues as a result of living with financial strain. It changed the conversation, as you'll hear, and led to collaborative discussions and partnerships and a new way of practice. But at the same time, community coalitions formed to take action on relevant, locally defined needs. They explored various assets, services in the community. And just knowing those services was not enough. They listened to the individuals and discovered what are the supports that they actually used, what were their experiences, their barriers, and their enablers in helping to find and seeking help. On the screen is an example of one of the personas the Central Zone developed. They used it as a reminder of that lived experience and what was important as they worked towards community action. Angela's story really highlights the cycle in and out of crisis due to financial to work, hospitalization, and that by listening to those community members and working together, teams made those iterative changes at both that community and primary care level. Angela's family's journey is not like others. It shows the challenges and opportunities we have to make a difference, and this cannot be tackled by one group. And teams that enabled that unique partnership across the sectors really started to make a difference. So as we think about improving the hospital transitions, imagine how this journey might look different today. How might Angela's outcomes differ from a warm handoff to community supports? How could hospitalizations been avoided if financial strain was identified and supported early? To help discover more, I'm pleased to welcome our panelists representing either the PCN or the community lead from 3 different teams. As you listen to their stories, we invite you to share your reflections and questions in the chat box. We present Joanne's story, Helpful Help.
I was the director of a family and community support service for 16 years. Occasionally, I was asked to sit down with frequent users of the food bank to see if there was any additional funding they could access or places they could cut back on spending. It was a simple request, and early on in my career, I thought that the answers would be simple. Stop drinking and smoking, get rid of your large pets, get a better job, and start making better financial decisions. I learned very quickly financial strain is a complex issue. We seldom found an easy solution to any of their difficulties. I realized that smoking and drinking were often coping mechanisms for trauma experienced in their life. Pets often took the place of human contact and nurturing, providing the unconditional love that people were missing. Some people just didn't have all the good health or skills and abilities necessary to get a higher paying job, or any job at all, even if opportunities were there. I remember most people saying to me in those conversations, "How do I budget better when I have no money to start with?" Our visit would usually end with me phoning the food bank and giving the go-ahead for them to have another food hamper. I often wondered, if there was no helpful help I could provide, why even have these uncomfortable conversations? Years later, in my new position as an AHS Community Health Promotion Facilitator, I received a phone call one morning from my manager about a pilot project called Reducing the Impact of Financial Strain. I was excited to get involved. The project goal of having healthcare providers screening patients for financial strain just made sense to me. I knew it would have great impact if we could pull it off. One of the first projects we did as a team was a poverty simulation in order to build understanding of what it was like to live with financial strain. I was a single parent of 2 children with a grandparent in the household. Each family was given a unique package that provided them with weekly tasks, a month's worth of money, bills to be paid, and items to be pawned if needed. The goal was to get through the month without running out of money. It seemed like there was just not enough time to get everything done. As a father, I felt guilty that my children didn't take part in after-school activities because they had to work or babysit. I forgot to purchase enough transportation coupons for all our family activities. We spent so much time just trying to access what we needed to get by that there was no time to improve our situation. I don't think any of us expected it to be such a powerful experience. After years of having these conversations with others, I had a much deeper understanding of their daily reality. Many of us commented about how it was so exhausting to live with financial strain, and we only did it for an afternoon. Together we realized how difficult it was to think about healthy living when all we could focus on was getting through the next week. And the conversation shifted to how the best healthcare in the world would not help us when we were living in financial strain. As communities, we can ask the questions, listen to the stories, understand each other, and learn to provide helpful help that supports us all to live healthier lives.
So as we chat with the Vermilion team, tell us what stands out to you about this digital story. We'll come back to your reflections in a moment. Thank you, Joanne, for sharing your story with us. Tell us a bit more. After listening to the experiences of individuals, including Angela's from our previous slide, can you tell us more about how you see helpful help today?
Watching that video, it just really came back to me how much work we've done on this and how incredible of a journey it's been. And going back to my first conversation with Angela from the persona that you saw there, she was so guarded in what she said to me. And I just found that as I just listened and encouraged her to tell her story, that she opened up about her feelings and experiences. And she began to trust me with her story. She was very honest. And she told me about her life and her family and what her struggles were and what she found helpful and what she found wasn't helpful. And just not what she really thought I wanted to hear, but she told me her honest story. So when engaging with people with financial strain, it's important to first be honest with ourselves about our own biases towards those living with financial hardship so that we can listen without judgment and to their life stories. I think sometimes we tend to draw conclusions about people based on outside glimpses of their lives, that they have big dogs or that they smoke or they have a big TV. But we need to actually walk with them to find out what their reality is, how they perceive it, what works for them, and what their challenges are and what they value. People living with financial strain have not had easy lives. Financial strain can involve a number of complex and traumatic life experiences, reaching back through generations of family members. When we as helpers provide patients with an immediate solution to their situation, without listening and really understanding what their situation is, we do not take into account the many obstacles and barriers that they may have to following through with our directions. Perhaps they do not have the money to purchase the prescriptions they were given, or their job will be in jeopardy if they have to go to an out-of-town appointment. Perhaps they don't have a vehicle or a driver to get them to that out-of-town appointment. Perhaps they don't have the money to purchase healthier food required for their diabetic diet, or the glucose test strips they need to monitor their sugar. The helper ends up frustrated because they see the patient as non-compliant and not following their directions, but they may have barriers that they're unaware of if we don't ask and listen with empathy. When people feel they've been heard, it gives them a voice, and they feel empowered to actively participate in their recovery to health. When we come from a place of authority and power and tell them what we feel they need without listening, we create codependence and breaking down of relationships. It has been so rewarding to have all these community partners at the table in Vermilion working towards improving the health and lives of those living with financial strain. Through our work together, we have increased awareness of what it means to live with financial strain and began to build a collective response to this very complex social and medical issue that affects all of our communities.
Natasha, clearly your PCN started from a place of empathy. Tell us more what practice looked like before and after this shift, and how you see this new standard of practice impacting patients' transitions.
Yes, thank you, Shauna. Before we at Kalina Country PCN started this project, our physicians and staff were very apprehensive about screening for financial strain. They felt like it wasn't part of their role, and they needed a social worker or patient liaison as part of their team. After attending the poverty simulation, staff understood what a great impact financial strain could have on their patients and their patients' health. It allowed them to walk in the shoes of their patients living with financial strain. Screening patients in person as well as virtually opened up a whole new dialogue. Patients felt more understood, and it created an environment for them to share more than just health concerns. Patient-staff relationships were tremendously deepened, and for the first time ever, it became clear why some patients' blood sugars continue to remain elevated despite numerous treatment approaches, or why some patients miss appointment after appointment, or why some patients frequently visit the emergency department. Physicians clearly saw the impact on health and healthcare utilization of their patients. Through active partnering with community agencies, we soon realized that we had numerous supports in the community, including social workers. We were now able to actively refer our patients to these supports. And our hopes are that all patients with financial strain who are discharged from hospital will feel well supported in their transition back home.
Thanks, Natasha, for those thoughts. Joanne, I hope you have a chance to check out the chat box. Lots of great comments coming in there. I think what's really some of the themes that are coming to my mind is that creation of the space to have those conversations so that you can get that deeper understanding of that patient and where they're coming from, so that some of their lifestyle choices and behaviors might make sense once you have that additional context, and just the general fatigue that these patients have to endure trying to coordinate all these services and resources just to survive. So with that, we're going to pivot over to our next digital story. We're really excited to show this one. It's from our St. Albert and Sturgeon team, and it's titled Invisible.
I remember when my dad let me drive his old beat-up truck to high school. I could feel people looking at me when I pulled into the parking lot, sounding like I was dragging empty tin cans behind me, and then parking it next to a classmate's BMW. It was the first time that I realized not every family had the same amount of money, and that people make assumptions about income depending on where you live or what you drive. There were many families like mine living in St. Albert and Sturgeon with little disposable income. After high school, I went into an LPN program, and I not only enjoyed it, but was good at it. Over the next 10 years, I had many different experiences, from acute care and neurosurgery to home care and dialysis. I followed my passion to Vancouver and was excited to return to my hometown a few years later. After being a nurse that cared for others, it was a shock to suddenly become a patient needing a lot of support from the system. In 2017, my son was born 2 months early, weighing only 2.5 pounds. My husband and I spent 2 months at our son's bedside in the NICU, neither of us able to work. Less than a year later, we were separated, and I was raising our son alone. In the early days, I had to make hard choices: diapers, food, or gas. On a few occasions, I had to put food back at the till. Holidays and birthdays were stressful, wanting to still provide a great experience, but worrying about the financial toll. I was often scrambling for childcare so I could get to work and pay the bills. It was humbling living paycheck to paycheck, and it made me appreciate my family and the supports I did have. I was lucky in that sense. I always had a great support system, and it got me through the long, dark days. It took time, but I have adapted, and my son is healthy and thriving. Still, every day, I meet people in my work as a primary care nurse and health educator that do not have the same supports I did. I know how small things can compound and negatively influence your health. I have often met with people struggling to leave an abusive situation, knowing that it would worsen the financial strain they were facing. I have also seen patients wanting to improve their health, but not being able to eat fresh vegetables or fill a prescription simply because they need to pay rent. Through my role on the RIFS team, I am proud to be an advocate and work with community partners to improve access to services. Working together, we ensure our community is a strong support system for those that may not have one.
So again, tell us what stands out to you, and we will come back to your reflections in a moment with Crystal's support. Thank you, Stephanie, for your powerful story. Pam, let's start with you. Stephanie's video really highlights how easy it is for those social needs to go unnoticed and yet have such a dramatic impact on health and family. How has your PCN team worked to ensure that the invisible is becoming more visible?
Hi, Shauna, thank you. At St. Albert and Sturgeon Primary Care Network, we responded to the needs of our invisible community members by changing our financial strain screening program to a nurse-led project versus physician-led. And that has fit really well with our medical home model. Our PCN's medical homes are built around team-based care, where physicians and clinicians work together to provide care. The idea of moving to the nurse-led project really took off at the beginning of the pandemic. Our nurses were reaching out to and connecting with our vulnerable patient population. They were phoning patients and completing wellness checks, which included assessing for financial strain. If patients were found to be struggling with any of the social determinants of health, our nurse could still discuss the patient with the physician and either determine a care plan that they could implement themselves or have the patient make an appointment to see their physician. Once we finished screening what we consider to be the vulnerable patient panel at each of our physicians' offices, we extended financial strain screening to all nurse patient appointments. We developed a clinician guide with a workflow for screening patients for our nurses. And we also developed an additional guide for resources available for our patients in the St. Albert and Sturgeon area. It made good sense to continue utilizing our chronic disease management and mental health nursing teams. One, because they were already doing the work, and then they often have more frequent and longer visits with the patients. The initial appointment is sometimes around 60 minutes and follow-up appointments about a half an hour. The length and frequency of these appointments can lead to greater opportunity to explore the patient's overall picture, considering their social determinants of health with every patient interaction. And because we work within a team-based medical home model, the physicians were still consulted when necessary. Our nursing team is also more familiar with the medical home neighborhood and better suited to connect patients to helpful programs, especially in the rural area of St. Albert. But throughout the project, our community innovation liaison, Stephanie, also built collaborative relationships with our Sturgeon County community partners, learning more about what is available for our patients in their rural medical home neighborhood. And that knowledge was shared back with both of our patients and our nursing team, which eventually would filter to the medical home.
Awesome. So Stephanie, as your PCN began to make visible those social needs in the community, tell us more. How did your PCN work with the community to respond to the social needs?
Yeah, thank you, Shauna. Ultimately, through the relationships built with community partners, as a team through RIFS, we realized we shared a common vision and a common goal. And this was the catalyst to our hard work building awareness and empathy, implementing community programs, and advocating for gaps in services. For example, the video you just watched was shared with community partners and then was used to lobby Morinville City Council. This was done to build awareness and secure sustainable funding for service gaps. It was a collaborative community partnership effort that included the PCN and the local family and community support services. Also, as a team, we were able to think outside the box to stretch funding and resources for unique programs, such as our backpack program. RIFS caught the interest of other community partners and exposed the impact in sharing stories to create or increase awareness for those experiencing financial strain and the available resources to help them. Ultimately, the work strengthened relationships between community partners, especially in rural settings. These strong connections help to bridge some of the service gaps and bring help to those that may not have been visible. For example, I'll share a couple stories. A patient screened positive for financial strain in their medical home. This person had recently lost their job and was living off of protein powder as their only source of nourishment. They had no money for food and needed access to a food bank immediately. Because of their unique rural address, there was confusion to which food bank they could access for services. Through relationships built, we were able to work as a team and connect with a community partner who helped clarify the service boundaries, and we discovered they actually belonged to a smaller community food bank, and they were able to get what they needed right away. We also helped connect them with government funding so they could complete some vital training to access employment available to them. A second example, we were connected with an individual who screened positive for financial strain in their medical home. Through building rapport and connections with this person over many visits, it was discovered that they were living in an unsafe and abusive situation, and we were able to involve other community organizations for help. Through the work of RIFS, we were able to connect this patient to neighboring community organizations as well to assist with their unique situation. Without the work of RIFS, these connections and the connections made, these success stories may not have happened. Yeah.
Thanks, Stephanie, for sharing your stories there. What I love about the St. Albert and Sturgeon Project is how you guys have really been able to come together as a community and accomplish things that on your individual parts, neither organization could achieve, but collectively you can. So that's always really inspiring. And there's lots of great comments coming in on your story. It always amazes me how many times I can watch these stories and still get goosebumps every time. So with that, we're going to transition over to our last story, digital story that we'll be sharing today. It's from our McLeod River PCN team, and it's called Puzzle Pieces.
I'm curious by nature, and I've spent most of my adult life advocating for people with disabilities and youth in my community. So when I read the job description for Community Innovation Liaison role to reduce the impact of financial strain, I applied. I am always eager to learn, and I wanted to find out more ways to support my community. In my work as an advocate, I saw how financial insecurity is hard enough for people, but then you add things like chronic pain, addiction, mental health, lower or no literacy, lack of social supports, or unhealthy supports, and the hundreds of other little things that can change and fill up the day. For many, it can often seem too overwhelming to move forward. At first, I thought once we had figured out how to reduce the impact of financial strain on the health of one person, we could do the same for everyone else. I quickly realized every patient had different abilities, challenges, and strengths. Every situation was unique. I tried my best to optimistically navigate what seemed at times as an ever-changing system, policies, procedures, and resources. I had to put the pieces of the puzzle together backwards. I started with the person in front of me. Who were they? What are their strengths and challenges? What did they need to access the resources to move forward? Ending with, what do we currently have in our community to improve their health and support their wellness? Our community, like every community, had gaps in services that directly affect financial strain. It was easy to see what we didn't have, But in the process of putting together the asset map with Courtney, the RIFS health promotion facilitator, I learned what we did have. I realized that most of the time we had the puzzle pieces, we just needed to communicate and have some common goals. Learning about how others served our community and identifying ways to partner was essential to reduce the impact of financial strain on people's health. Almost a year after I started, Lacey, the RIFS improvement facilitator and nurse that I work with closely, told me that she had started to notice something changing in the clinic. Patients they used to see 1 to 2 times a week weren't coming in as often. The only thing that she could identify that was different was the screening tool used at the clinic and the referral to the PCN wellness program. The clinic didn't seem to be the center of their care circle, the community was. As my role in RIFS is coming to an end, I am most thankful for the grace and kindness that was shown to me. For me, the RIFS project created the opportunity and safe space to have a much needed conversation specifically around financial strain, not only with the people that I serve, but the healthcare providers and the community organizations that I connected with. What we are able to do collectively as a larger group, in my opinion, is the answer to a lot of questions.
Powerful insights in all these digital stories. Thank you, Tara, for your story. Oh, again, we invite you to tell us what stands out for you, and we'll come back to your reflections in a moment. We would love to hear more, Lacey, about how your team is starting to solve the puzzle pieces for each patient. What impact have you seen from your team's collective approach?
Thanks, Shauna. We've seen the impacts of our approach at both the clinical and community level, and it's just been an increased focus on creating space in routine encounters to have these difficult conversations around financial strain. Oftentimes, these conversations, they will piggyback on appointments that the patient would have booked for an alternate reason. Taking the time to ask about the financial barriers that patients may be experiencing, but may not think have a relevance to their health, has just created a shift in how we begin to break down these barriers. By beginning the conversation, our clinical team has been more able to identify early on which key team members that will be needed to help assist the patient navigating the appropriate resources, and then we can pull them into the consults for that. The RIFS work has impacted our team's mindset by prioritizing the need for improved connections with not only our PCN services, but other community resources as well. We know that the more our team responds collectively with patients, the more impact there has been on the patient's quality of life. For example, we can see the impact of our team's collective approach at both the clinical and community levels by looking back to a young man that we've seen in the clinic with type 1 diabetes. He was attending school and living at home with his mother when we first met him. His diabetes was wildly out of control, and despite our best efforts over the next few months, discussing medication titration and meal planning, nothing seemed to improve. It was only when we created the space for discussing the barriers to his health that he reluctantly began talking about his challenges with financial strain. This was information that he felt reluctant to share, and without feeling supported to share it with us, he may never have. It was this single conversation that we had that we were now able to discover what really matters to him and how we could best help him navigate these barriers to meet his health goals. He is now receiving financial assistance, has access to food resources to fight food insecurity, is receiving assistance to find employment, and has been able to share some underlying mental health concerns. Although his journey is far from over, we now know where he needs the most support in order to succeed. So we hope to continue building connections with our community and continue to promote the widespread shift in mindset towards easing the pathways for resource collaboration across our community.
That sounds amazing. Tara, you've worked with many of these community members with financial strain, including patients that have been discharged from hospital. How is your team's approach support those that are experiencing financial strain?
Can you hear me?
Yep.
I'll ask it every time. The importance of relationships with each other within the health neighborhood cannot be overstated. When teams collaborate, it is an opportunity to identify challenges and collectively support our most vulnerable. When being able to meet someone where they're at and using a strength-based approach in a positive way is, from what I've experienced, a positive way to move some complex clients forward. When I'm supporting clients and their documentation and paperwork, it's identified quickly at times they struggle with low or no literacy. They share that they are overwhelmed with the volume of action items and struggle to sort out what is important. Often the information is too complex for them to attain or understand. Some other barriers with transition is that some people do not have stable housing. They could be living rough or homeless, and that circumstances change quickly, and many cannot afford to fill the prescriptions, and some may not be attached to a medical home. Having positive community connections to resources is key to ensure the tasks are achieved and people feel supported during the process. Throughout the RIFS project, I've been able to work with our team to increase awareness of what is available within our community to build client community capacity along with clinic staff and physician knowledge. I like at the end of the videos and the tie between all the videos of creating the conversation and removing the shame of a much needed conversation. So look forward to finishing off.
Thanks, Tara, for sharing those insights. As a Whitecourt team, you guys have really done an outstanding job, and you guys are really passionate about the area and doing so much good work at trying to spread it to other communities within your PCN and area. And so your efforts are acknowledged, and you guys really need to give yourself a pat on the back for the good work you're doing in the community with your patients and at the zone level too. So now we're just going to transition over to a Q&A section. And so when I look back at the chat and the comments coming in about what a common theme, there's a lot, and I'm going to put this out to all the panelists and all the PCN teams. The role of assumption and just looking at patients and how sometimes that patient can present in a way that doesn't indicate that they're in financial strain, but they actually are. So what would be your advice to teams wanting to take on this work to overcome those assumptions?
Lacey, do you want to start us off?
Sure, absolutely, and that's such a great question, because the assumptions has really been the focal point, or the aha moment for me during this RIFS work, is that it goes so identified. You might be able to see other diseases present a little bit more physically, but financial strain is just, it's one of those things that it's the biggest barrier when you wouldn't think it would even be on the map. So I think just creating the conversation, creating a safe space for the patient to feel comfortable sharing with you, that they're not just going to share this really personal or this really private aspect of themselves, and that you won't be able to do anything, but that they can really see your intention. I want to intentionally ask you these questions so I can intentionally help you. So I think that was kind of our biggest takeaway from it, is changing how our encounters are formatted so that a patient feels comfortable to share that information, and that we're not just gonna, leave them unassisted or say, oh, I'm sorry, we can't help you with that. We're really going to try our best and leverage any connection we might have. And Tara is a rock star at this, at leveraging all of the connections that we have in the community to find some help.
Thanks, Lacey. Do any of the other PCNs want to weigh in how you've helped your clinicians overcome that hump of asking this private, personal question?
At St. Albert and Sturgeon PCN, we started to share those successful interactions or success stories, because sometimes staff would make a referral and maybe not know what would happen. Or like Lacey said, they would feel they were asking an intrusive question, and it really wasn't part of their role as a healthcare professional. But being able to go back to the clinic and say, actually, the patient you referred upon further investigation was living in an unsafe housing environment. And this is the background to what's been happening to him and with elder abuse and whatnot. And for Stephanie to be able to share how she was able to assist him with resources, and they did great work. Like, they made a plan, like what would happen if the situation in the house escalated, what would be your next steps. I think that really went back to our nursing team as, even though it might feel awkward to ask the question, there's so many benefits to it if the patient feels that they can share with you, because you can really help them in ways that they might have not been helped prior to.
Thanks, Pam. Well, we could probably spend a whole day just talking about this conversation, but I want to give Dr. Joseph Ojedikin a few minutes to close things up for us. He is a physician lead with our McLeod River PCN team, and he works at Life Medical. And so he's he's been such a great leader for us, so strong, leads by taking action and coordinating his community and taking the first step to be the first clinic in his PCN to try this out. So without further ado, I'll turn it over to Joseph.
Thank you very much. Can you hear me well, everybody?
Yeah, I can.
Yeah, thank you very much. Yeah, I really want to congratulate all the teams that did this job. You've done a very great job, and it's a continuous work, and there's no doubt about that. And thankfully, we're bringing this into transitions, and that means we are bringing it into acute setting, into hospital. We're trying to spread the mental model. And I think that's something actually I should say quickly. What you are trying to address, or what we're trying to address here, is the way we think. And you will agree with me, changing the way we think is not easy. It's a great job, but it's not an easy one. So a good place to start definitely is increasing the awareness and talking about it, sharing these slides, the video recording, and, everywhere, PCN level, the clinics, with our staff, with PCN staff, even our AHS colleagues. That's what we're trying to do. You agree with me, it's difficult to change the way we think. And how should we be thinking? There are two ways, there are two things really I think we should be doing, like Lizzie said and other people have said there. Ask what matters to the patient. What matters? What matters. We are trained to ask what matters with patients rather than not what matters to them. What's important to them? I'll give you an example. The last patient I saw this morning, I'm just trying to make it very practical. Say is a 49-year-old man with diabetes. Actually, Lacey and I saw him together. The last time I saw him was about 3 years ago. He has diabetes which is poorly controlled. And obviously, he felt we're going to be talking about, oh, your diabetes is not well controlled. You need to make it better. You need to do this. You need to do that. You need to exercise. You need to whatever. But I just jumped on the couch and I asked him, I said, okay, Mr. XY, what matters to you about your health at this stage? And he opened up his mind and said, look, do you know what really matters to me? It's my stress level. My stress level is up to the roof. So it's really changing the way we approach caring for people, really asking that question, what matters to them, listening to what matters to them and doing what matters to them, not trying to care for people with a preconceived agenda, and creating that culture within our clinic, within the hospital, as they are being admitted, as being discharged. What's the home situation like, and what's happening? And again, we don't know how many people is going to be listening to this recording, but it really spreads across every aspect of our healthcare system. The second thing really is teamwork. And the main point I want to say there is, if you want to go fast, go alone. If you want to go far, go together. If you want to go fast, go alone. If you want to go far, go together. That means know your partners, know your community partners, you know those people you can collaborate with, that can help your patient. Those days are gone when we think of the primary care as just a clinic. Primary care is no longer just a local clinic. It is a clinic. It's a local clinic working together with home care, with EMS, with community paramedics, with even RCMP, addictions and mental health, social services, victim services, employment services, and all those community agents. Know who those people are. Train the people that are working around you to identify those people. We did a survey here, I think about 4 years ago, amongst hospital staff in our hospital in Whitecourt, to just ask people, how many of the services do they know that they can navigate patients to? Only about 4 to 6% of our hospital staff know the community services they can navigate patients to. So it's a very important job. And so I appreciate you guys, working on improving the awareness, letting us know that it's important to ask, to listen, and to do what matters to our patients, and to focus on teamwork. So as we end today, again, we don't know who's going to be listening to this. If you're a PCN executive director, perhaps you should look at arranging a poverty simulation for your member clinics, your physicians, your staff. You can just to show them what it means to be in poverty. Many of us have not experienced it, and so we don't really know how to empathize with patients. Ask yourself, is your PCN equipped, with the human and program resources to address the social determinants of health? And ask yourself, how high on my list of priorities as an ED is addressing social determinants of health? As a primary care physician, when that patient comes into you with headache, ask the patient about their employment. Is their accommodation threatened? Are they feeling lonely? Are they depressed? We don't just focus on the physical symptoms. What community resources are you familiar with? And how confident are you that if your patient is experiencing social determinants of health, that they can comfortably discuss those things in your clinic? Are your clinic staff, are they trained to navigate patients with social determinants of health, coming to community services? If you work in social services in a community, how well are you collaborating with other people, with the clinic, with the hospital to assess and support patients that are vulnerable in your community? Are you working by the books, or are you working by the patient's needs? So these are important questions I think I'm hoping and we can all take away today and ask ourselves if we can change one way that we think. I think this presentation would have made would have really worth it. Thank you very much.
Thank you, Dr. Ajetikin. Such wisdom in your words and great examples that you've provided. And I'm seeing in the chat box, there's some really powerful examples of work that you're also doing. And so as we sort of reflect on what do you plan to do next, it seems it would be really valuable for all of us to connect and continue sharing. And there's an opportunity to do that on our Together for Health website, on that platform. And as well, we really invite you to share these digital stories. And we have many more that that Mike is supporting and facilitating. And so stay tuned and use those digital stories to start a conversation. And as well, take a look at the hospital to home guidelines if you're not familiar, and reflect on what you can do next as it relates to that important work. Certainly, if you have questions, connect with us, but we encourage all of you to connect with each other, and hopefully we've got a nice mapping feature that we're going to invite you in an email to share and network with each other. So just to wrap up, I want to thank you so much, say a big thank you to our panelists and speakers today, and a huge thank you to all of you for joining us during your lunch hour on a Friday. As we leave today, again, as Dr. Ojedikan had encouraged you, what is the one change you could make in your work that will impact patients with financial strain as they transition from hospital to home? So check out our website,